Okay, let's dive right into this explainer. We're going to translate 44 incredibly complex U.S. healthcare terms into a clear, understandable journey. Look, if you've ever stared at a medical document and felt like you were trying to read some ancient, lost language, well, you are absolutely not alone. Today, we're taking that massive, dense list of industry jargon and turning it into a narrative that actually makes sense.
To get through this dense glossary, we've organized everything chronologically into 5 easy steps. 1. Getting your coverage. 2. Visiting the doctor. 3. Decoding that medical bill. 4. Paying your share. And finally, 5. Navigating advanced complexities.
Let's kick things off with Section 1, Getting Your Coverage.
So, right off the bat, who is who? It really comes down to the subscriber versus dependents and beneficiaries. You see, the premium is that regular payment, usually monthly, that keeps your protection active. Now, the subscriber is the person or the employer actually footing that bill. But the beneficiary? That's anyone who is actually eligible to use those medical benefits. Usually the subscriber's spouse and kids are covered too, and they are specifically classified as dependents under the insurance contract.
But coverage isn't always a magic switch that flips instantly. Your timeline actually starts on the effective date. That is day 1 of your official eligibility. But wait, you might hit a waiting period. This is a specific gap between your effective date and when the plan actually assumes liability for certain services. We see this all the time with pre-existing conditions, which are simply any illnesses or injuries you already had before that effective date kicked in.
Moving right along to Section 2, Visiting the Doctor.
Once you actually go in for care, the insurance company relies on a very strict 24-hour rule to categorize your visit. If you're admitted to a hospital for medical care and you stay for more than 24 hours, you're an inpatient. Anything less than that, or if you're just getting treated in a standard doctor's office, you're an outpatient. It sounds super simple, right? But hitting that 24-hour mark completely changes how your insurance views and ultimately processes your visit.
Now, when you need specialized care, there is a very specific workflow you have to follow. Step 1, your primary care physician, your general family doctor, gives you a referral. Step 2 is the specialist consultation, where they actually provide advice or map out a treatment plan. But then we hit Step 3. For certain procedures, like eye surgery for instance, the doctor's office actually has to call the insurance company to get a pre-certification number. This pre-authorization is literally just making sure the insurance company knows what's happening beforehand, so you can be absolutely sure they'll cover it.
And behind the scenes, every single physical location where you receive care is meticulously tracked using place of service codes. An office visit, that's an 11. An inpatient stay is a 21. Outpatient is 22. Emergency is 23. It even goes all the way up to code 34 for hospice care, which is specifically for patients suffering from a terminal illness with a life expectancy of 6 months or less. Literally, every location has its own specific identifying number.
All right, let's look at Section 3, Decoding the Medical Bill.
Okay, here is where the numbers game truly begins. You absolutely have to understand the massive difference between the billed amount and the allowed amount. The billed amount is just what the doctor charges. They can essentially charge whatever they feel is fair. But the allowed amount? That's the fixed, predetermined price the insurance will actually pay, based on their master list called a fee schedule. So regardless of how astronomically high that billed amount is, the insurance will only ever recognize their specific allowed amount for that service.
Let's put this into perspective with a real-world math scenario. Imagine 2 different doctors both bill $100 for a service, but the insurance's allowed amount is only $80. The first doctor is a participating or par provider. They have a contract with your insurance. So they get paid that $80 and they literally just write off the remaining $20. Your responsibility? 0. But the second doctor is a non-participating provider. They do not have that agreement. They get the $80 from insurance, they take 0 write-offs, and they leave you, the patient, entirely responsible for that remaining $20. And that $20 patient responsibility we just talked about, that is exactly what we call a balance bill. It's an extra charge you might face when you see out-of-network or non-participating doctors. Because the doctor has 0 contract with your insurance, they are perfectly within their legal rights to bill you for the exact balance between what they charged and what the insurance actually paid.
Which brings us right to Section 4, Paying Your Share.
The biggest hurdle here is your deductible. This is the initial out-of-pocket amount you absolutely must clear before your insurance steps in to help. Now, this could be a yearly deductible that resets every single January, or it could be a lifetime deductible. If it's lifetime, you pay out-of-pocket up to a certain massive limit, let's say $5,000, and then for the rest of your life on that specific plan, the insurance has you covered.
Now let's break down the two other main out-of-pocket costs, copayments and coinsurance. A copayment is a flat, specified dollar amount. Think of it like paying a $50 toll every single time you see a specialist. It's totally fixed. Coinsurance, on the other hand, is always expressed as a percentage. So instead of a flat fee, you might be responsible for 20% of whatever the final allowed amount is for a big surgery.
But don't worry, there is a ceiling to all of this. It's a two-way street. Your out-of-pocket expenses are what you actually pay, but your plan has a contract maximum. That is the absolute hard limit the insurance policy will pay out for a calendar year or a specific illness. So if your massive dental surgery costs exceed their $5,000 per year maximum, suddenly you become responsible for the excess.
Finally, let's jump into Section 5, Navigating Advanced Complexities.
So what happens if you actually have more than one insurance policy? Well, through something called the coordination of benefits, they actually work together. If you have a $200 bill, your primary insurance might pay 80%, which is $160. That leaves your secondary insurance responsible for the remaining $40 balance. Why do they do this? To make sure no one gets double paid, so you literally can't profit from being sick. If the secondary pays that full $40, your balance is zero. And believe it or not, some people even have tertiary or third-level insurance just to mop up whatever tiny fraction might be left over.
You're going to see all this math clearly broken down on a document called your Explanation of Benefits, or EOB. Now, an EOB is not a bill. I repeat, it is not a bill. It's literally just the insurance company showing their math, proving exactly how they calculated their share. And this is crucial because secondary insurances physically need to see a copy of that EOB from the primary insurance before they will pay a single dime.
And behind all this mountain of paperwork, your doctor and their business are being tracked by an absolute alphabet soup of identification numbers. The actual human doctor, the rendering provider, has a PIN. They might even have a UPIN, which is an additional 5-digit alphanumeric identifier. But when the actual money changes hands, the business entity itself is identified by a tax identification number, or EIN. It is a seriously complex web of tracking. So we end our explainer today with one vital question. When you inevitably face a denial, a flat rejection of payment by your insurance company, will you exercise your right to submit an appeal and fight back? Look, navigating this glossary shows us that the healthcare system is highly structured, deeply numerical, and heavily regulated. But now that you know the actual language of the system, the real question is, the next time a confusing medical bill shows up in your mail, are you just going to pay it blindly, or will you use these definitions to audit it line by line?